I am Sandra Buttigieg, President of the European Health Management Association, a consultant in public health at Mater Dei Hospital and a professor of health systems management and leadership at the University of Malta. It is also my privilege that I am chairing the Patient Safety and Quality Improvement team at Mater Dei Hospital in Malta as well. The 17th of September is World Patient Safety Day and is one of the World Health Organization's global public health days. It was established in 2019 by the 72nd World Health Assembly through the adoption of Resolution 72.6 titled Global Action on Patient Safety. Against this background of the ongoing COVID-19 pandemic, which has exacerbated the risk of medication errors and associated medication-related harm, medication safety has been selected as the theme for the World Patient Safety Day of 2022, with the slogan, Medication Without Harm. The global campaign reaffirms the objectives of the World Health Organization Global Patient Safety Challenge, Medication Without Harm. This was launched by the WHO in 2017. We also have the strategic framework of the WHO Global Patient Safety Challenge, and this is titled Medication Without Harm. This was launched in 2019. As we can see here, this depicts 4 domains: patients and the public, healthcare professionals, medicines, systems and practices of medicine. Each area, each domain has 4 other subdomains. So in total, there are 16 subdomains. And we have 3 key actions. And as we can see, these are in the center, because every domain and subdomain can actually feed into these 3 key action areas, namely polypharmacy, high-risk situations, and transition of care. What are the statistics? So the question is, why do we bother about patient safety? A very recent publication by OECD titled Developing International Benchmarks of Patient Safety Culture in Hospital Care reports that 1 in 10 patients continue to be harmed from safety lapses during their care. Globally, unsafe care results in more than 3 million deaths annually. It also has a high financial and economic cost. Indeed, in developed countries, the direct cost of treating patients who have been harmed during their care approaches a very big figure of 13% of health spending. Now consider if those 13% are used for more meaningful and needed areas in healthcare. Healthcare settings, therefore, can be very dangerous places, can be unsafe places, also not for our patients, but also for health workers who experience a number of harms, including exposure to infectious diseases, physical harm, and psychological harm. We have a number of statistics coming from across mostly the developed world. Taking the United States and taking the reality of the patient safety, this chart struck me when at the bottom it says that the reality of patient safety is losing people like having 2 jumbo jet crash a day with no survivors. And then we look at who is the most vulnerable. We have statistics, for example, that roughly 1 out of 6 children entering the hospital will be the victim of an error. We also have studies that show that 440,000 American patients will lose their lives due to preventable errors in the hospital. Now, this was a study in 2013. Of course, there are many, many more studies. With regard to statistics about specifically the cost of medication errors, we have as well from the United States a number of statistics. At least 1.5 million preventable adverse drug effects occur in the United States each year. 1 in every 150 patients admitted to hospital dies as a consequence of an adverse event. Administration errors account for 26 to 32% of total medical errors, and nurses administer most medications. Unfortunately, most administration errors aren't intercepted. As we've said, who is the most vulnerable? Children are 3 times more at risk of errors than adults because of the complex dose calculations they require. Again, looking at the financial side, avoidable costs from medication errors is $20 billion, with a range of $15 billion to $28 billion. And up to 9% of inpatients experience medication-related harm. We also have some statistics, and important ones as well, from Europe. So, patient safety issues and medication errors do not spare any country. 1 person per million dies every day because of a medication error. Hospital patients are prescribed from 5 to 9 medications during an admission. 18% of European citizens claim to have experienced a serious medication error during hospital admission. It is also suspected that approximately 3% of deaths in the Swedish population are because of medication errors. Of course, we can only show statistics from countries that have done the audits and research. Medication errors represent the highest rate of adverse events in hospitals. In the UK, from the financial side, it is estimated that the cost of medication errors have ranged from 98.5 million in the UK to 2 billion euros in Spain. And this is approximately 3% of these countries' national health expenditures. Again, posing the question, what can we do with those 3% rather than having them wasted because an error has occurred? Coming back to the health professionals involved directly or indirectly in an incident. And this does not just affect patients, which is, patients and their relatives are the first victims, but we also have the psychological and emotional harm suffered by healthcare professionals who, at least the people I've met in my career, have gone into the healthcare profession because they want to help patients. They want to make the patients better. They want to manage patients, treat patients, cure patients. Which brings me, therefore, to what news goes out there to the media. And we know that we have the media that picks up stories. Some of them become sensational. But by and large, we are notified also by medical journals, journals from the nursing profession, that medication harm risks not only patients, but also healthcare professionals' well-being, and that does undermine the trust in health systems. Here we have a story of a nurse that actually, was on the media, and it came out that it has become that every nurse's nightmare, that if you commit a medication error, and sometimes it is not due to entirely the human factor only, but also the human interaction with the operating system that is the cause of the error. The same we've heard about medication errors from medics, as we see here in the case of this oral surgeon that prescribed the wrong dose of fentanyl. So here we are, many stories that hit journals and the media. Which brings me to the term of second victim, which was coined by Albert Wu. Albert Wu published this on the BMJ in 2000 as a personal view. And he had a story to tell, that medical error he noticed during his observation as a house officer, where he was involved in a story of with another resident who failed to identify the electrocardiographic signs of the pericardial tamponade that would rush the patient to the operating room late at night. And as we see, the news spread rapidly, and the case tried repeatedly before an incredulous jury of peers who returned a summary judgment of incompetence. And this affected Alberto, and he actually coined this term of second victims. Indeed, the work by Alberto has been carried forward not only by Alberto, but by many others, including a cost action that I am part of, which is known as EARNST, the European Researchers Network working on second victims. I am leader of Work Group 4 and dealing with barriers and facilitators in implementing second victims programs. And indeed, on the 26th April 2021, I chaired an international virtual meeting during which we invited none other but Alberto, who is there as one of the participants here. There you could see me chairing the meeting, and we also have colleagues from the Betsy Lemon Center and Professor Jose Mira, who's the chair of the action, and my colleague Lucia from the Irish College of Surgeons. So in this meeting, there were 100 participants from 27 different countries, where we actually discussed the implications that patient errors have on healthcare professionals, and therefore on second victims. One cause or another have become involved in a patient error. And this brings me on, therefore, that if we look at the statistics of patient safety culture, again, the publication by OECD posed the question, how do hospital workers in OECD countries feel about patient safety culture? The answers are on the positive side. So if we deduct that from the 100%, then we get the negative side. So here we have 40% of hospital staff think that staffing levels at their workplace are appropriate for ensuring patient safety, which means that more than half think staffing levels are too low to ensure safe care. 46% of surveyed health workers believe that important patient care information is transferred across hospital units and during shift changes, which means that more than half think important information is lost when patients are moved or staff changed because of shifts, for example. 50%, half of the workers believe that their hospital management provides a work climate that promotes patient safety and shows that patient safety is a top priority. Indeed, claiming that leadership support is an essential part of building a strong safety culture, and patient safety could become a higher priority for leadership. Very important, 52% of surveyed hospital workers feel that staff freely speak up if they see something that may negatively affect a patient and feel free to question those with more authority. And therefore, this means that almost half feel that reporting safety events results in punitive responses within a blame culture to those that report them rather than learning from them. So what do we mean by a patient safety culture? This involves having beliefs, values, and norms that are shared by healthcare staff. So patient safety culture is what is rewarded, supported, expected, and accepted. And it exists at multiple levels. So it is not just at the level of the person, of the individual, but it is at the level of the system, of the hospital, of the department, and of the unit. So what should we be promoting, even as EMA, as the European Health Management Association? We should be promoting that there has to be a paradigm shift from a person-centered view of the error to a system-focused view of the error. Why? because the person-centered view of the error gives us an incorrect execution of procedures. It could be, we just say that it has been a communication problem, a one-off, a misunderstanding. But no, we need to prevent future errors from happening. And that's why we need to take a system-focused view of the error, because we need to understand that humans are fallible. To err is human, and errors are to be expected, even in the best organizations. And indeed, errors are caused by systemic factors and not by just one cause. And here I refer to the Swiss cheese model by James Reason, giving us various levels, the latent errors, various slices of the cheese having latent errors, and then the last piece, which is an acute error, where actually that error occurs. We need also to have a paradigm shift from punitive actions in terms of disciplinary measures, threats of denunciation, blame or shame those involved, to developing more and more a learning organization style of working, changing working conditions, and getting to the root cause of the error, asking questions how and why did the defenses that are very nicely illustrated by James Reason's Swiss cheese model failed. So these are important, pertinent questions. In 2022, we are living the digital age, and therefore we know that digital tools, technology, digital tools and solutions do exist that can help us, that can be a means to helping us err less, because of course the human mind is what it is, and therefore digitalization will give us more precision. Yet levels of digitalization of medication management in the EU hospital settings are low. And we know that medication is the main part of the therapeutic process for hospital patients, with errors more likely to occur in complex care situations, like the intensive care units and the oncology units. But the reality is this, that many hospitals do not have automated unit dose medication systems. And there is low availability of electronic prescription. So we are still having handwritten prescriptions, which may not always be legible. We also have low preparation systems in critical areas in some parts of Europe. We have low availability of barcode medication systems to safely adhere to the 5 rights of the medication. We have very limited near-miss infusion medication errors that are tracked via systems to reduce those errors. And also very low availability of electronic medication cabinets, estimated less than 20%, A, because they are expensive, and B, because, of course, when you have the adoption and implementation of innovation across countries, this may take time and needs resources. So while most hospitals have electronic systems, they are not available for all patients and are not supported and are not aligned with clinical decision support. There's more that can be read from this white paper that is also worth a while to read and spend time on. However, building cultures of safety is as important as implementing new digital systems to reduce patient harm from medication errors, meaning that we should not rely on technology only. We have to look at the basics. We have to look at the foundation in terms of values, beliefs, and knowledge that we should have in order to ensure a patient safety culture. And as we said, we need the safety, the psychological safety that has a direct influence on improving patient safety. That means the safety to speak up if you notice that something is not right, even if you are the junior member of the team, even if you are not part of the profession that is in the lead in that particular intervention. Psychological safe workplaces are those where employees feel comfortable taking interpersonal risks, such as pointing out an error. And as Young et al. Published, organizations with robust safety cultures significantly reduce the incidence of medical errors. Error reporting is negatively affected in psychologically unsafe hospitals, of course, because people will be afraid to talk. Because if they talk, or if they are whistleblowers, they are not seen by some organizations in the right light. Employees are less likely to report an error than employees working in psychologically safe environments. Again, referring to the World Health Organization, has done tremendous work on patient safety. WHO notes that judicious balances between a no-blame policy and accountability are indispensable components of safety culture in hospitals. What is EMA's position? And I have to say that in my years at EMA, patient safety and quality of care has been the #1 priority in every activity that we've undertaken. Either this has come directly or indirectly. Indeed, EMA has created an alliance of 12 Brussels-based NGOs representing healthcare professionals. And these include hospital pharmacists. We also have patient organizations and industry to advocate for digital innovation in hospitals to increase and support patient safety. So the alliance position is to mitigate and prevent medication errors. It is crucial that cultures of safety are created and medication management is digitized and automated in hospital settings in collaboration with healthcare professionals. This will also enhance healthcare staff's well-being, productivity, and satisfaction levels, reducing workload. It may take time until we reach that, but we need to invest and take this to a higher leverage whereby we have minimal unintended consequences. We need to increase hospitals' resilience. And this also will have benefits of decreasing bed occupancy, shorter admissions, and therefore we know that hospitals could be the source of further infections. So the less the duration of your stay in the hospital, the better. This will also generate real-world data on medication use, namely prescribing, dispensing, disposing, and ordering. And finally, this will also support efforts to combat situations like antibiotic resistance arising from and associated with overprescribing of antibiotics. At some time during our lives, antibiotics used to be prescribed even over the counter in some healthcare systems. And of course, we need to raise the alert that this is not to the benefit of patients and to the benefit of European citizens. So I would like to thank you, and I hope you did enjoy this brief presentation that will mark, as we said, World Patient Safety Day 2022. And I do wish you a fruitful conference. Thank you.